Imagine your immune system suddenly gets handed, like, a corrupted set of blueprints.
Oh, that's a good way to put it.
Right. And instead of protecting your skin, it just launches this highly coordinated demolition project on the most sensitive, often stigmatized parts of your body.
Yeah, it's devastating.
It really is. So, welcome to another deep dive. Today, we are opening up a massive stack of clinical guidelines, including the latest from the British Association of Dermatologists and BHH.
That's the British Association for Sexual Health and HIV, for those wondering.
Exactly, thank you. And the mission for you, the listener, today is to unpack a highly misunderstood chronic skin condition called lichen sclerosus, or LS.
And we really want to synthesize this complex landscape, right?
Yep.
Because there is so much noise out there.
Ton of noise. We're pulling from medical journal excerpts, patient leaflets, all to figure out how this condition is actually managed.
Yeah, and we are specifically zeroing in on a really debated topic today, which is the role of topical hormones as an adjunctive therapy.
Yes, the hormone debate. It's huge in the source material.
It is. And we're also going to deconstruct this pervasive steroid phobia that, honestly, it actively prevents patients from getting relief and halting that demolition crew you mentioned.
Right, because before we can even parse out the treatments like steroids or hormones, we need to understand what LS is actually doing.
We have to look at the cellular level.
Exactly. So the sources classify lichen sclerosus as an inflammatory scarring dermatosis.
Which is a mouthful.
It is, yeah. But basically, it's an autoimmune process that predominantly targets the anogenital region.
Right, so we're talking about the vulva, the perineum, the perianal area, and the foreskin in uncircumcised men.
And the symptoms are brutal. It's this unremitting itch that spikes dramatically at night, severe pain, and these white parchment-like plaques.
Yeah, the visual changes are very distinct.
But you know, what really stood out to me in the immunology literature wasn't just the surface stuff. It was the structural damage happening beneath those plaques.
Right, because the rogue immune response is targeting the basement membrane zone of the epidermis.
Okay, break that down for us. What does that actually mean?
Well, essentially, your T cells are releasing these inflammatory cytokines that just break down the healthy, elastic architecture of the tissue.
The demolition crew at work.
Exactly.
Yeah.
They destroy the normal collagen and elastin, and they replace it with this rigid, hyalinized scar tissue.
Wow. And that's why patients get those severe anatomical changes over time.
Yes. In women, the chronic scarring can literally cause the inner labia to physically fuse to the outer labia. Or the clitoral hood can scar over and totally bury the clitoris.
That sounds incredibly painful. And for men.
For men, the scarring of the foreskin creates this rigid ring. It leads to severe phimosis, where the foreskin can't retract at all, and eventually it can even obstruct urinary flow.
Which is just, wow. And to be clear, I want to jump in here for a second to clarify what LS isn't, because the stigma is real.
Oh, absolutely.
It is not an infection, it's not contagious, and it has literally nothing to do with poor hygiene.
It's purely an autoimmune misfire.
Exactly. And when looking at who it affects, the demographic data shows this distinct bimodal distribution in females.
Right, the two big spikes.
Yeah, it spikes sharply in prepubescent girls, and then again, much more massively in postmenopausal women.
And that timing is not a coincidence.
No, it correlates directly with these drastic shifts in the body's baseline hormonal ecosystem. When estrogen levels are inherently low, the whole local tissue microbiome and the pH alter significantly.
The tissue becomes much less resilient.
Right, and that might expose new cellular antigens that the confused immune system just suddenly decides are foreign threats.
Yeah, the immune system just gets triggered.
Yeah.
And while it is an inflammatory process, all the guidelines are unanimous on the stakes here.
The long-term risks.
Yes. Lichen sclerosus carries a 4 to 5% lifetime risk of developing into squamous cell carcinoma.
Wait, really? So it can actually turn into skin cancer?
It can. The localized chronic inflammation forces the skin cells to just rapidly and continuously divide to repair the damage.
Because it's constantly being attacked.
Exactly. And anytime cells are forced into this state of hyperproliferation, the statistical probability of a genetic mutation occurring
and leading to malignancy
goes way up. That mechanism is exactly why proactive aggressive management is not optional. You have to shut down those inflammatory cytokines.
Which brings us perfectly to the universal gold standard across all the guidelines, from BSH to the BAD.
Heavy artillery.
Yes. The primary weapon to halt the immune attack is an ultra-potent topical corticosteroid, Usually clobetasol propionate 0.05%.
And this is where we hit a massive psychological roadblock for patients.
The paradox. Okay, let's talk about this because this requires a real deep dive into the pharmacology.
It confuses so many people.
I mean, logically, it makes sense why they're confused. You get this diagnosis, right? You pick up the prescription, you open the box, you unfold that little pharmacist's leaflet.
And it has those bold warnings.
Yes, in huge letters, do not use on the genital area. And prolonged use causes skin thinning.
Which sounds terrifying to an LS patient.
Exactly. You're holding a medication for a disease that is literally already thinning your skin, making it tear like wet tissue paper, and the box says it'll make it thinner.
Right. We call this the steroid paradox. And honestly, it is the single biggest driver of treatment failure.
So how do we explain this to someone? Why is the leaflet right for a normal person, but totally wrong for an LS patient?
Okay, so we have to look at how steroids interact with fibroblasts. Those are the cells that produce collagen.
Okay, fibroblasts. Got it.
If you apply an ultra-potent steroid to totally healthy skin, it actually suppresses normal fibroblast activity. So over time, yes, that leads to skin atrophy or thinning.
But the LS skin isn't healthy.
Precisely. The disease itself is hyperactivating pathways that destroy normal tissue and lay down that thin, fragile scar collagen.
So the steroid is acting on the disease, not the skin.
Yes, it targets the hyperactive immune cells. By neutralizing the T cells, the steroid halts the disease process. And once that inflammatory assault stops, the surviving fibroblasts can finally wake up and resume normal, healthy collagen production.
Oh, wow. So it doesn't thin the skin in this context. It actually removes the barrier to healing.
Exactly. It allows the skin to actually thicken and regain its elasticity.
That is a massive aha moment. But the guidelines are really specific about how to safely deploy it, right? To get that exact result without side effects.
Precision is key. They recommend what's called a fingertip unit.
Which is just a line of ointment from the tip of the index finger to the first crease of the joint.
Exactly. That volume is the precise dosage you need to cover the affected anogenital area without getting it on surrounding healthy tissue, like the thighs.
Because if it gets on the healthy thighs, that's where you'd get the unwanted thinning.
Right. That's why using a mirror during application is so heavily emphasized in the clinical literature.
And what's the actual schedule for this?
It's a taper. You apply it once a day for a month to get that initial remission. Then you step down to alternate days for the second month, and finally twice a week for the third month.
And then just maintain it.
Yeah, the goal is a long-term maintenance dose, usually once or twice a week, indefinitely. To give you an idea, a standard 30-gram tube should last a patient about 3 to 6 months.
That's a tiny amount of medication per application. But I notice in the clinical trials, when a patient says the steroid isn't working, biopsies show the inflammation is still just raging.
Because they're underdosing.
Exactly. The steroid phobia from that leaflet makes them apply this microscopic smear, or they just stop the second the itching goes away.
But the autoimmune blueprints are still in circulation. If you pull the steroid away completely, the T cells just march right back to the basement membrane.
And resume the demolition.
Exactly.
Okay, so steroids are the heavy artillery that stops the attack. Now we have to pivot to the secondary focus of the source material, the highly debated role of topical hormones.
This is a really interesting area.
It is, because LS peaks during low estrogen states. The historical assumption was just, well, replace the missing hormones and fix the disease.
Right. And for decades, the go-to treatment was actually topical testosterone.
Wait, really? Testosterone for a female-dominated condition?
Yeah, the rationale back then was based on testosterone's anabolic properties. Doctors figured applying an anabolic hormone locally would force that thinning skin to bulk up.
But the guidelines say that's a terrible idea now, right?
Oh, totally dismantled. The current guidelines definitively state that topical testosterone has zero evidence base for treating LS.
Like none at all?
None. In randomized controlled trials, it was literally no better than a placebo of petroleum jelly. Plus, it gives patients awful systemic effects, like unwanted hair growth and clitoral enlargement.
Wow, okay, so testosterone is out. But what confused me is that the BASH guidelines heavily feature topical estrogen.
Right, which seems contradictory.
Yeah, like if LS is an autoimmune misfire and not a primary hormone deficiency, why are dermatologists prescribing localized estrogen alongside the steroids? Should people just throw their hormone creams away?
No, absolutely not. And the nuance here is crucial. It's the difference between treating the disease and rehabilitating the environment.
Okay, explain that.
Topical hormones, like estrogen, do not reduce the autoimmune inflammation of LS, period. If you stop your clobetasol and only use estrogen, those T cells will keep destroying your tissue.
So it's not a replacement.
No, it's an adjunctive therapy. Because LS mostly strikes postmenopausal women, these patients are almost always suffering from a secondary condition at the same time, atrophic vulvovaginitis.
Right, the extreme dryness and thinning from the lack of systemic estrogen.
Exactly. That drop in estrogen makes the tissues profoundly dry, pale, and fragile, entirely separate from the autoimmune scarring.
Okay, I love this analogy for my notes. Think of the steroid as the fire hose, right? It rapidly extinguishes the active flames of the autoimmune fire.
I like that.
But the topical estrogen is the carpenter arriving the next day to rebuild the charred, weakened support items. The fire is out, but the house is still damaged from the drought.
That is a perfect way to visualize it. When you apply localized estrogen directly to the vaginal and vulvar tissues, it binds to local receptors. It stimulates glycogen production.
Which feeds the healthy bacteria, right?
Yes, the lactobacilli. It restores the acidic pH. It also promotes angiogenesis, which is the formation of new blood vessels.
So it's literally bringing blood flow, moisture, and elasticity back to the area, complementing what the steroid just saved.
Exactly. That dual-pronged approach is the absolute cornerstone of modern management. The steroid halts the disease on the outside skin, and the estrogen plumps and revitalizes the mucosal tissues.
Which makes sense because stripping away the inflammation often just reveals that underlying atrophy.
Yeah, patients treated only with steroids often still report discomfort or painful intercourse.
So BASH categorizes topical estrogen as a vital, supportive add-on. It's not one or the other.
Right. You need both to rehabilitate the pelvic floor.
Okay, so beyond the prescriptions, every single source we reviewed dedicated a surprising amount of space to everyday heroes. Emollients and barrier creams.
Oh, they are so critical.
Like just plain Vaseline, Aquaphor, or Cephraben. The BSH guidelines don't just call them moisturizers, they position them as active protective equipment.
Yeah, because the mechanism is physical, not chemical. The skin barrier in an LS patient is completely compromised. It's full of micro tears from the scarring,
And urine contains uric acid.
which is incredibly irritating to broken skin. So a thick layer of petrolatum creates this impermeable shield. It physically blocks the urine and sweat from getting into those tears.
And it also prevents the anatomical fusion, right?
Yes, because the inflamed tissues want to adhere to each other. Keeping the area heavily coated in a slick emollient denies the skin the friction it needs to form a scar bridge.
So the advice is basically abandon harsh soaps, wash only with an emollient, dab dry to avoid microabrasions, and just reapply that barrier cream all day long.
Multiple times a day, yes.
Okay, but what about second-line defenses? What if the steroids fail or someone actually gets steroid atrophy from over-applying?
Then we look at topical calcineurin inhibitors like tacrolimus and pimecrolimus.
Right, and my understanding is these ointments block calcineurin, which is an enzyme that activates the T cells driving the demolition.
That's correct.
But if people are so scared of steroids, why aren't these the first choice? The BAD guidelines explicitly warn against using them as a first-line therapy.
Well, there are three major flaws. First, they are clinically inferior to clobetasol in actually halting the disease.
Okay, so they just don't work as well.
Right. Second, compliance is awful. They are notorious for causing an intense burning sensation when you apply them.
Oh, wow. Applying liquid fire to raw, inflamed tissue.
Exactly. Patients abandon them very quickly. And third, there's a theoretical oncology concern.
Back to the cancer risk.
Right. We established LS patients have that 4 to 5% risk of SCC. Calcineurin inhibitors suppress the local immune system without the rapid anti-inflammatory cascade that steroids have.
So dermatologists worry it might increase the risk of malignant changes.
Or mask the early signs of a carcinoma. So they're strictly reserved for specialized clinical oversight when the gold standard just fails.
That makes a lot of sense. Speaking of things that might fail, we have to touch on the experimental frontiers.
Ah, the buzzy new treatments.
Yeah, you Google LS treatments and you get bombarded with clinics advertising fractional CO2 lasers, stem cell injections, platelet-rich plasma.
Very key, yeah.
They market it as this cutting-edge cure without steroids. But the consensus statements universally classify them as strictly experimental.
Because they treat the cosmetic symptom, not the systemic cause.
Right, like a CO2 laser just vaporizes the top layer of scarred skin.
And PRP just floods the area with growth factors.
Yeah.
But neither of those alters the corrupted blueprints the immune system is holding.
The T cells are still programmed to attack.
Exactly. You might get a temporary visual improvement, but the autoimmune fire is still burning underneath. Without rigorous trials proving they stop the progression to cancer, they can't replace steroids.
And I guess that exact logic is why surgery is generally avoided, too.
Oh, absolutely. You
Mhm.
can't surgically cut away an autoimmune disease. If you try, the immune system just aggressively targets the new surgical scars.
The Koebner response, which we'll get to in a second.
Exactly. So surgery is only used as a salvage operation, like dividing fused labia to open a sealed vaginal canal, or a medical circumcision to restore urinary flow.
Or removing a cancer.
Right.
Okay, so synthesizing all this data, the protocol is clear. LS is a chronic condition that requires lifelong respect,
Yeah.
lifelong vigilance. You stop the immune demolition with ultra-potent steroids, you use hormones as adjunctive therapy to rebuild the environment, and you protect with emollients.
Yes. And we can't forget the call to action for the patient. Ongoing self-surveillance.
The monthly mirror checks?
Non-negotiable.
Yeah.
So you have to check for persistent redness, nodular lumps, or most importantly, any ulcers or fissures that refuse to heal despite the steroid routine.
Catching those cellular changes early keeps them highly treatable.
Exactly.
All right, as we wrap up, I want to leave you with a fascinating concept buried in the margins of the dermatology literature.
The Koebner response.
Yes, we learned that the immune system in an LS patient can actually be provoked into attacking specific areas.
Right. Physical friction or trauma to the epidermis causes the cells to release stress proteins.
Like a chemical flare gun.
Exactly. In someone with an autoimmune susceptibility, those stress proteins draw the rogue T cells right to the site of the mechanical trauma.
And boom, a new lesion starts.
Yes.
When you think about that in the context of our modern world, it raises some really profound questions.
It really does.
I mean, we constantly construct our lives around physical friction. We wear highly restrictive synthetic clothing that traps heat. We sit for hours.
We do high-friction activities like indoor cycling or horseback riding in compression fabrics that don't breathe at all.
Right. So if physical microtraumas can dictate precisely where the immune system launches an attack, we have to wonder.
How many localized immune responses are we unknowingly triggering?
Exactly. Are we inadvertently firing those chemical flare guns and handing our immune system the blueprints to destroy healthy tissue just through the repetitive friction of our lifestyle?
It really forces you to reevaluate your daily habits. Rethinking how we dress, sit, and interact with our environment might be a critical first line of defense.
It certainly changes my perspective on wearing ultra-tight athletic leggings all day.
Oh, for sure.
Well, thank you for joining us as we unpack the science behind the symptoms, keep analyzing those guidelines, keep searching for the mechanisms, and we'll see you next time.